Hi everyone, my name is Michelle Guadalupe and I am with the Arthritis Foundation. First, I wanted to apologize for us being a little bit late. We just had a few technical difficulties, but we wanted to go ahead and get started with today's Step Therapy Virtual Town Hall. The Arthritis Foundation is part of the State Access to Innovative Medicines, which is helping to put on this town hall today. For those of you that are watching this live, please feel free to ask questions for our panelists. In order to do so, simply click on the small icon that looks like a grid right above the video, and a Q&A box should appear. Click there to submit your questions. So if you'd like for a particular panelist to answer that question, please include that information. And if for some reason you're not able to ask your question during this virtual town hall, please feel free to email me. It's mguadalupe@arthritis.org, and I'll go ahead and repeat that at the end of our town hall. I really wanted to say a huge thank you to our different organizations that have helped put this together, and that includes the Illinois State Medical Society, the Sangamon County Medical Society, the Mental Health Summit, the Arthritis Foundation, and the National Psoriasis Foundation. And we also wanted to thank all of our panelists for being with us today. I'll be introducing them in a few minutes, but first I wanted to start off this virtual town hall by sharing a short video that will help you provide an overview of the step therapy issue.
It's a familiar scenario for most of us. You get sick and go to the doctor. Your doctor takes your medical history, examines you, makes recommendations about your treatment, and may write a prescription. But for many patients, the process of getting the medication prescribed by their doctor may be very complicated. Insurance companies have policies that can block access to medications your doctor prescribes. Many patients face these roadblocks while fighting serious chronic diseases. Step therapy is one such policy. Also known as fail first, step therapy does what it sounds like. Patients have to go through a series of steps, taking other medications and failing on them before the insurance company will pay for the medication originally prescribed by their doctor. That's because insurance companies use step therapy to cut costs. These requirements do not reflect the discussions patients just had while visiting their doctors. Despite their years of medical training, doctors' judgment and the doctor-patient relationship are being undermined by step therapy. In some cases, patients are required to try and fail numerous medications, some of which may not even be FDA approved for the condition being treated. Patients may also be required to take medications they previously tried without success. Step therapy delays access to the medication the doctor already deems best suited for the patient. In the course of these delays, patients may experience disease progression. Step therapy can also result in nearly 1 in 5 patients not receiving treatment at all. Moreover, step therapy policies burden doctors and healthcare workers. They may have to contact insurance companies to determine if they'll cover the prescribed medication, or perhaps file an appeal if the medication is denied. This takes away precious time that doctors have with their patients. So what can be done to help patients? Patient groups, doctors, and people can access the right medicines at the right time. Some states are developing legislation to regulate step therapy and ensure it is safe for patients. These regulations would implement standards and regulatory oversight to ensure patient safety. Ensure rules are based on published peer-reviewed clinical guidelines. Establish exemption rules so that patients and doctors can bypass step therapy when medically necessary. Ensure a transparent process to request an exemption. Laws like these help make sure that the doctor-patient relationship guides patient care, and that patients can get the medication their doctor ordered.
The website that was just listed, the prescription process, it does have that video on it, so you can look at it again. It does provide a really good overview about step therapy and why organizations like the Arthritis Foundation and others, we really want to look at this issue, and how it does impact our patients and our doctor-patient relationship. So I did want to do a quick overview of our panelists for today, and then we'll get right into the different presentations. We are excited to have Illinois State Representative Laura Fine from the 17th District up in Glenview on our panel today. She is the prime sponsor of this year's STEP therapy bill, which was House Bill 3549. We also have Professor Mark Heyerman. He is a clinical law professor at the University of Chicago and is a facilitator for the Mental Health Summit. We have Dr. Stephen Stone, who's a dermatologist and director of clinical research in dermatology at Southern Illinois University. We have Dr. Doreen Siri, who specializes in pediatric and adult asthma, allergy, and immunology. And we also have Jangmi Johnson, a physician assistant. So with that, I want to say thank you to all of you for being here today. And I wanted to begin with State Representative Laura Fine. She introduced the bill this past session. House Bill 3549 is very important for patient and provider organizations in our coalition. We want to make sure that the STEP therapy protocols don't interfere with the doctor-patient relationship. We know, Representative Fine, that the House has been called into session today, so we know your time is very limited. We wanted to say thank you for being on the panel today. And with that, would you be able to provide us an update on what is happening with STEP therapy across the states, including Illinois?
Sure. Thank you for having me today, and thank you for accommodating my time. I appreciate it so much. Before I go into that, I'm going to tell you a little bit about this legislation and why it's so important to me. About 5 years ago, my husband was in a accident and became an amputee. And along that came a tremendous amount of phantom pain. And his doctor knew the exact medication that would work for him. Instead of being able to take that medication that he would work, he had to spend many months, and we had to spend much money to go through the STEP therapy process in order to get to the goal that we knew that we wanted to get to. And so I personally know the type of toll that's on not only the patient, but the patient's family as well. So the frustration that goes along with it, the pain that goes along with it, and especially know that there's a resolution and we just need to get there. So that's what we're trying to address in the legislation. Our goal of this legislation is to put the patient's health first. We know that there are a number of other states that have already issued STEP therapy bills and laws into their system. Connecticut, Louisiana, Kentucky, Vermont. And what they've done is they've put outcomes first. And in this handful of states, they've passed laws that target commercial health plans and their use of STEP therapy. They have established regulations for clear criteria for physician fraud, and they also
Hi, Representative Fine. I apologize for the interruption. We are having some audio issues with your feed, so I know it is a little bit of a challenge, I think, for our listeners to hear. But we do really appreciate you, joining the call today and being such a huge supporter for our different coalitions, both patient and provider. For those audience that are listening, State Representative Fine was going through and discussing that Illinois is not alone in that many states have been introducing legislation across the country for STEP therapy, and we definitely do. We will be introducing this legislation again when session begins again in January. What we really want to accomplish with this particular legislation is we understand that some STEP therapy protocols do need to be in place. However, when we hear from patients and they went through that STEP therapy and they went on one, they failed. They went on another medication, they failed. They finally found the one that worked for them, and let's say that their job switches their insurance. So now they have to, they're on a new insurance, and that company says, you know what, you actually now need to go through this process again. That's where we really need to have those safeguards in place for the patient. But I don't want to go into too much more detail because I know many of our providers, on this list, on this panel, can really go into a lot of those different examples about patient-provider relationships. And I know we would love for all of those on the call today, on the virtual town hall, to get more involved with our coalition. And we really need patient stories. And maybe some of these conversations that you hear from the other panelists, it'll kind of spark something with you, and you'll be like, oh, I have some of these different patient stories. And we also need conversations to happen with our state legislators so that they know this is an issue. Either you have a patient or you're a provider, just so that they understand. I know State Representative Fine was going into a personal story that had happened to her. So with that, I know State Representative Fine, you're actually on your phone right now calling in for this virtual town hall. I do know you need to go to the House floor, so thank you so much, and we apologize that there were some technical difficulties.
Thank you, and thank you for hosting this conference. It is so necessary in this bill. We need to get asked to help patients in Illinois.
Great. All right, well, we look forward to talking with you again soon. So with that, I want now for one of our strongest patient advocates, Professor Mark Heyerman. I'd like him to talk about how step therapy impacts the patient populations, specifically for those with a mental illness. So Mark, how have health plans, how have these step therapy protocols affected patients in Illinois, including those that you represent?
Well, there's so many people in any state, certainly in Illinois, that have a mental illness. At least 250,000 people in Illinois have serious mental illnesses, and 2 million have other mental illnesses. And we have great medications for mental illness. Unfortunately, doctors don't know necessarily which one is going to work until they've tried them. And then when they finally find a good medication, no doctor that I've ever met would change that medication. If the patient likes it, the symptoms are being treated appropriately, and there are minimal side effects. Unfortunately, insurance companies and other payers often will say to the patient, you must stop taking that medication because it's not the cheapest, and you must now try a new medication. And I have had, for example, one client who they finally found what was the right medication, and he was on this medication and successfully living in the community, doing wonderfully. They took him off the medication. During the next 18 months, he was hospitalized 12 times. And so we need to prevent that kind of process in which, when the doctor already knows what the right medication is, and the patient likes the medication, that the insurance company should not be allowed to say, oh, you must start over and try a new medication. And some of the medications that my clients are being required to use, as was indicated earlier, are medications that they've already tried and they already know won't work. The doctor knows they won't work. The patient is reluctant to try them again precisely because they have not worked in the past. And when you end up in the hospital, that has consequences for you. It costs all of us a lot of money when you end up in the hospital because that's expensive. And you may end up doing things that you don't wish to do and that are harmful to your family. You may lose your job if you get too sick and are not getting the right treatment. This is very tragic because so many of these medications work so well for people with mental illnesses when they get the right medication, not the wrong one.
Great, thank you. And have you noticed, I know you've been working in this field for a while, have you noticed that step therapy has this become an increasing trend that you've seen?
Yes, that's unfortunately the case. More and more insurance companies are doing this as an effort to save money. I don't think in the end it saves money because it costs people's lives and their health. To fail with a mental illness, to fail with the treatment of mental illnesses, to have real suffering. People really suffer. They get very serious symptoms, sometimes including hallucinations and other bad things happen to them. and serious depressions. And of course, some of the outcomes for untreated mental illness include suicide. These are things that we shouldn't be experimenting with people's lives just in order to save money.
Great. We really do appreciate your insight. And just as a reminder to those that are watching right now live, if you do have a specific question, please go ahead and get that question submitted. We would love to be able to answer those. So with that, I wanted to say thank you again to Professor Heyerman for being here and really providing insights on how step therapy has impacted our mental health community. So now I wanted to hear from Dr. Stone, and I would like him to provide his perspective on how step therapy affects his practice and treatment of patients. So Dr. Stone, how have health plans become more aggressive with step therapy?
Oh, clearly, when we first started with the concept of step therapy, it was a matter of the insurance company requiring that you prescribe a generic medication in advance of a branded product, or a less expensive generic in advance of a more expensive product. But now we're required to jump through a lot more hoops than that. Very often we have to go through 2 or even 3 of the less expensive, perhaps generic and perhaps even brand name products that are not the preferred product before we can get to the one that we know will work. As a dermatologist who works with chronic patients, I can tell you that I know my patients very well. I know that this particular patient, for example, can't be given a drug that might affect his liver because perhaps of his lifestyle or other issues. But sometimes I've been told by the insurance company, no, they have to try that. They might have to give up drinking, but they have to try that medication before they can go on to the next. Because the physician generally knows the patient very well, that physician is likely to understand which medication is going to work and which is not. Now, we talk about the healthcare dollars. We certainly don't want to waste healthcare dollars, but the medication that doesn't work is the biggest waste of dollars to begin with. And quite frankly, being forced to jump through this hoop of repeated applications. We just finished the month of July. A number of Illinois insured patients have policies that roll over on the 1st of July. Others in January have their policies roll over. An insurance company will often say, new insurance company, you're prescribing a product that works, maybe worked for 2 years. Patient has a new insurance company and now is told, no, you have to try brand X before we can continue to pay for brand Y. And this all really denies the physician the ability to determine what is best for the patient. Normally the doctor-patient relationship is you and me. And when you throw in the insurance company as a barrier between doctor and patient, the best you can do is slow down the quality of care. Every month spent on a medicine that's not working is a month wasted and a delay in care. It's just not right.
I can see, I know on our video we talked a lot about that doctor-patient relationship, and you yourself was just talking about how you've been noticing, that there has been that change. Have you, just like with Professor Heyerman, so you've noticed a significant increase with step therapy and how that's impacted your practice?
Oh, it's become quite burdensome, not just for me and my practice, but for my patients, because of the increased likelihood that whatever we prescribe is going to have to go through a first-generation step. The truth of the matter is that in terms of medications available for dermatologic disease, we've had an explosion in recent years of really effective medicines that didn't exist for us 5 years ago. Unfortunately, we're being forced to use those medicines that we had 5 years ago because they're less expensive, to try them, and then if they don't work, when they don't work, then go on and appeal to the insurance company for the opportunity to give that medication. The other thing is, quite frankly, when we talk about the cost of medical care, the average dermatologist's office spends 2 hours at least for every step therapy patient. That's somebody in the office is on the telephone, is typing letters, is appealing the denial. And so this adds to the cost of operating a medical practice. It doesn't directly affect the patient, but it indirectly affects the patient. So part of the problem in dermatology today is the tremendous wait to get an appointment. Well, you're waiting to get an appointment because I'm busy on the phone dealing with the other patient's insurance company.
Thank you. I know we're going to have a few more questions for you later in the presentation. So again, thank you for your insight. I'd now like to turn it over to Dr. Siri, who is a specialist in asthma, allergy, and immunology. So Dr. Siri, can you provide examples of patients having to get inferior therapies, and how has this negatively impacted their health, and how has it impacted them financially?
We have certainly plenty of experiences where the patients are having difficulty with getting the care that they need, and it's not only costing them time and money, but certainly mentally and in terms of their health, it's quite impactful. One of the prime examples is an asthma medication. You know, of course, in the past 10 years, we have not had a significant improvement in the impact of asthma. There's still a huge amount of morbidity and mortality from asthma. People do die every day from asthma attacks. And for those severe patients, those hard to manage patients, the ones who are taking their medications, there are a litany of new medications that are available, but unfortunately they are expensive. And the insurance companies have put many hurdles on getting these medications that may be quite effective, that have proven to decrease the amount of steroids which are harmful to the body. They've shown that people have used less medications overall, and that have controlled their regimen, and also that have decreased hospitalizations. But in order to get the medication, not only do they require them to be on 3, 4, 5 other medications, but they also sometimes require that they have been hospitalized. So think about the absurdity of that someone has to have had a life-threatening experience in a hospital before they can be offered this therapy, despite the fact that we as physicians are doing our best to keep them out of the hospital to manage them well. So step therapy is not always about quality of care. Sometimes it can be, but certainly in many cases it's about the almighty dollar. Other examples, we have patients who are complicated. They have immune problems. If they don't get infusions of medications to replace their immune system, they potentially can get infections that are life-threatening and can die. So yearly, we have to, of course, go through the pre-authorization process, which takes an inordinate amount of time. But in addition to that, yearly, we have to establish they could continue to have an immune deficiency. Nothing has changed for the patient. The patient has not had any changes in their labs, their values. The only thing that has changed for the patient is that now they aren't getting sick every month. They aren't getting pneumonias. They are no longer being hospitalized. Yet they want us to go back to the original 15, 20 years ago when they first developed the immune deficiency and establish it every single year so that people can continue to get the infusions. And with the delay, it may take a month or two to acquire all that paperwork to document these things for the insurance companies. And so the patients are delayed in getting their life-saving infusions for a month or 2 months. And every month or two that that patient doesn't receive it, one, they have the opportunity of getting a life-threatening infection. And two, the insurance company saves money for those 1 or 2 months. It is absurd. And so there are certainly a lot of serious diseases that are being overlooked. But even from simple treatments, such as allergy, many of the products are now over-the-counter, which is a boon and fantastic. But the over-the-counter medications are now being dropped from formulary, so insurance companies won't pay for them. They simply will say, try an over-the-counter. Other examples are things like nasal sprays. Now that there are 2 over-the-counter nasal sprays, they will require patients to fail 3 nasal sprays before they will allow a different class of medication entirely in order to pay for that. So it impacts everyone from, common diseases to unusual diseases.
Great, thank you. Thank you for your insight. I know we're going to start getting questions from the audience, so we'll definitely be coming back to you as well as some of our other panelists. But hearing that, in hearing those different examples you provided, I think will be helpful to the audience.
I think that it's not simply just about changing up the therapies. When this is a clear example I have from asthma. Is that when first some of the asthma guidelines came out years ago, the insurance companies took that to say that some of the medications that were being prescribed a lot and were branded medications, expensive. So sometimes the information is discordant from the insurance companies. For example, many patients were being prescribed a pill, which was a non-steroid, in order to control mild asthma. It was being prescribed so much because it was popular and a good medication that then the insurance company said, well, you know what, you really should be prescribing an inhaled corticosteroid because it's proven to be more effective than this pill. And that was a cost-driven decision. And then a couple of years later, they changed their mind and said, well, we don't really want people on steroids, and we should go back to the other therapies. And the reason was that then, because of the shift, people started prescribing a combination steroid with a controller medication, and that medication was being overprescribed, also a branded medication that was expensive. So sometimes the information from the insurance companies is quite discordant, and they run away with this information. It is often the case that when we write letters to insurance companies for denials, which I do every day, every single day I write letters, the insurance company will note that the treatment is experimental or investigational. But you know, so many medications that we use for therapies, we as physicians who have trained find these medications effective. They treat the patients. They may not necessarily be for that indication, but simply it's easy for the insurance company to say, well, we consider what you want to treat with this patient experimental and deny it, when realistically it is the only medication that could be working for the patient. And so really it is about insurance companies dictating what the patients can do and not do. In any other field, if you think about a service agreement for your home or service agreement for your car, nowhere else will they say, well, you have to try these 3 other things first before we'll fix your problem. And so when it's vital to our livelihood, I don't understand why insurance companies can have that kind of authority.
Thank you. You're a very passionate physician, and thank you for being on this panel for us. We do want to have our last presenter speak first, and then I know we've already received several questions, so then after she goes through her portion of the panel, and then we'll start answering those questions. So Jang Mi, as a physician assistant, you see the impacts of step therapy every day. How does step therapy impact a physician and his or her staff?
Firstly, hi everyone. Working in Chicago, I have a very diverse type of patient population. I have patients on Medicare, I have patients with private insurance, and I also have patients that have no insurance. So when we're dealing with, say, a patient with private commercial insurance, and I'm writing a prescription for acne medication, and it's a patient that I've seen for the past 8 years, and they've been on the same acne medication, and they're just coming in for, a refill. But they may have gotten a new job, and now they're required to go through this step therapy process for a medication that they've been on for 8 years, and it's very frustrating. Most of the insurance companies want to know what has the patient tried and failed in the last 6 months, and you can't honestly say that they've tried and failed anything because they've been on the same medication. A lot of times those patients get their prescriptions denied, which means that I have to go back to the beginning, much like Dr. Stone was explaining. We have to go back to the beginning. And when we have patients who are suffering from things like acne and psoriasis, and they're on medications and therapies that are working, and you have to go back to the beginning, a lot of times their conditions flare. Some of my patients become very depressed. And so it's a safety issue as well as, a financial issue. And the simple fact is, it's almost like the insurance companies are practicing medicine by telling us, well, you have to use this, and if that doesn't work, then you have to use that. It's a very frustrating system that we're working through. We're lucky enough now to have certain pharmacy partners that are allowing us to get some of our medications for our patients, and kind of going through this step therapy on the back end versus delaying therapy for the patients that are either currently on a medication or really require one of these newer medications that may not necessarily be on a formulary or be on the very, very high tier of a formulary. I can also say that step therapy is also works in procedures. A lot of my psoriasis patients, we have light therapy in our office. We also have excimer laser. So excimer laser, for those of you who aren't familiar, is a UV laser that you can actually use to pinpoint active plaque areas versus putting someone in a light box and exposing their entire body to UVB rays. So again, you might have a patient who only has a plaque on their elbow or a plaque on their knee, but they have to actually be exposed to a UV box before their insurance company will say, okay, well, let's go ahead and approve the laser, which only targets the area that's actually affected, which is safer for that patient. So it's difficult in all aspects of practicing medicine. And there are even some cases where a generic medication can be denied because the patient didn't try a different generic medication. It's been a little silly in the past 2 years.
Now, when you were talking about having to do appeals, the exception process, what would you say are success rates? How much time does this take for you as a physician assistant? Just the whole overall burdensome that doing these files can be on the practice.
In our practice, in particular, I tend to do my own prior authorizations. So I'm on the phone quite a bit or writing letters quite a bit for my patients because my staff members may not necessarily know the nuances of the information that's required on some of these forms. So I could easily be spending at the end of my patient care hours, and by the way, I work 10-hour patient care days, so an additional 2 hours just filling out paperwork or staying on the phone, and sometimes I even have to take lunchtime or on my days off to call an insurance company to discuss whether or not I can get a medication for my patients. In the meantime, I have to supply them with samples which still may not be sufficient for their therapy.
So part of that video where it showed the 78 unopened emails and the phone calls, that really kind of hits home then, it sounds like, for many of our panelists, and just having to deal with all of that different paperwork.
Yeah, it was a very realistic video.
Well, we do appreciate it. We do have quite a few questions, so I know we're going to come back to you as well. But thank you so much for providing your insight and sharing with us the real impact that has had on patients and their health outcomes and getting those different medications. So we have been having quite a few questions come in. I did want to start off with the questions and have Dr. Stone address the first one. How often do patients get frustrated and just stop taking meds when you're dealing with this step therapy?
We don't have really good statistical data, so I can only tell you from my own personal practice. I'm a dermatologist, so most of the conditions I deal with are issues of quality of life. We used to say psoriasis doesn't take your life, it just destroys it. So dealing with quality of life issues, it's not at all unusual for a patient to say, I can't afford a $1,200 deductible on this particular medicine, or I can't get the medicine I need that I know works, and I don't want to take this because it might damage my liver. And so I see patients every day, whether it comes to a cream or a systemic drug, who tell me they stopped taking it because of the hassle with the insurance company, with the insurance coverage. Yes, at least every day, somebody will come in and say, I couldn't use that medicine because the insurance wouldn't pay for it, the deductible was too high, etc.
Would any of the other panelists, if you wanted to share any of your stories about kind of patient frustration, I just wanted to open it up and see if anyone else would like to comment.
Yes, very commonly, people with serious mental illnesses just feel that there must be something strange going on when the insurance company denies medication to them, and they just give up. And particularly because these are medications that people often need to take for their lifetime, and people don't necessarily like to take medications for their lifetime. So when they run into hassles, many of my clients have given up their medication when they have gone to the pharmacist and been told, well, this isn't the right one, your doctor prescribed it, but now you must go back and get a different prescription from the doctor. Very frustrating for them, and some of them just say, I don't have the strength to do this if I'm seriously depressed or if I have other serious symptoms of mental illness. It's easy to give up on the mental health system, on the prescription system under these circumstances.
Would anyone else like to comment before we go on to the next question? Jangmi, I know you started talking a little bit about the burdensomeness in your office. I wasn't sure if there was anything else that you wanted to add, because we did have a question about what this does for staff time, and that it doesn't seem like it's all that easy to manage.
Well, in our office, originally I didn't start out doing my own prior authorizations. When we were paper, our patients would go to the pharmacy and hand their prescriptions off to the pharmacist, and then we would get a phone call or a fax from the pharmacy stating that this medication requires a prior authorization. Well, when we went electronic, we would send our prescriptions electronically. And almost immediately, the moment we send that prescription electronically, within 2 to 3 minutes before the patient even leaves the office, we already have faxes from the pharmacy stating that this medication requires a prior authorization. And considering I'm seeing about 45 to 55 patients on a daily basis, and if they're getting multiple prescriptions, that's 45 to 50 faxes just from me that are coming in from the pharmacies. And it became very overwhelming for our staff to call. It takes a good 20 to 30 minutes per medication to get a prior authorization at least started, but not even necessarily finished. It became a point where our physicians were deciding that our front desk staff and our back desk staff were better off serving by answering phones versus making phone calls. So I decided that if I'm going to write a prescription for one of my patients, that I will be responsible for making sure that I've done everything that I can to get their prescription. And again, it's kind of slowly gone back to the point where we do have staff members that are calling, some of my medical assistants are calling, but again, I really feel that there are certain nuances that they may not necessarily understand on what information they're looking for and what information they need. So for a point, we almost had to hire someone just to do prior authorizations, but even if we did that, we probably would have had to hire 2 or 3 people just to do prior authorizations. There are 8 providers in our practice, so it's extremely overwhelming, and to get the fax before your patient leaves, it's very disheartening, because you know that the patient isn't going to get their medication that day. They may not even get their medication that week.
Thank you. We did have another audience question, and this one is for any of our panelists. This is their question. Is it a bit insulting for an insurance company to prescribe drugs when they didn't go to medical school?
It's a bit insulting, actually, to have somebody on the telephone tell me why I shouldn't be giving this patient medication A and should be giving medication B, when you know that this is not only not a physician, but not a medically trained person, and they're just reading it out of a notebook. So yes, in that sense, it is insulting. It's also insulting as a matter of corporate policy for me to know a patient, to be dealing with a patient, to understand that patient's disease, and have somebody tell me that it's corporate policy that I give some other medication first. It's insulting, it doesn't make sense, and in the long run, I'm convinced that it injures the patient, whether it injures their wallet or injures them health-wise. There's no doubt in my mind that this is not the optimum medical care that I would like to be delivering to my patients.
Dr. Siri, would you like to add any follow-up to what Dr. Stone had mentioned?
I actually have an example of that. It was a patient with an asthma medication, and it was a no-brainer. The patient was being controlled with 3 medications. And so, for some reason, I got a request for a prior authorization and a denial on a medication that was approved for asthma and the patient's second condition, which was nasal polyps. So the person on the other line, who was a trained professional, stated the reasons that they denied it. And they denied the reason was that the patient should be controlled on the current inhaler they were already being prescribed. So I said, well, they aren't, and they need this other medication, not for 1 condition or 2, and I thought that was the end of the conversation. And the conversation went on, well, I'm sorry, we're denying it because they should be controlled, and guidelines say they should be controlled. And I said, well, you can tell the patient what the guidelines tell her. So it really is ludicrous sometimes, the things that we hear.
Unbelievable.
Sorry, I just muted myself. That is exactly why, and I know when State Representative Fine, introduced this legislation, we had several, exceptions in there. And really, when you see, that doctor who's had the medical school and has had, knows the clinical guidelines, there needs to be exceptions to this. So, because you're telling, you've seen it actually happen, that, well, you know what, this isn't working for that patient, so then I should be able to prescribe the medication that is working. So yes, I can see how frustrating it is for you, and also especially how frustrating it is for different patients. Another question from the audience: do you think in the long run it will cost healthcare providers more money to utilize step therapy?
I can take that. I don't necessarily think that it will cost the healthcare providers more money to deal with step therapy. Probably cost the insurance companies more, because that means that the patient has to come back to our office to be reevaluated multiple times. They have to use multiple medications and then eventually get on the more expensive medication that they could have started with in the beginning. So in the long run, I think that step therapy is probably more expensive than just allowing a physician or a physician assistant or a nurse practitioner to prescribe a medication that they feel is appropriate for their patient's condition.
Would anyone else on the panel like to also chime in?
I would like to say that it's not simply expensive for insurance companies. It is expensive for society overall. I think most physicians try their best to prescribe generics when possible, to try to conserve therapies and not prescribe unnecessary treatments or diagnostics. And of course, the insurance companies track us and see how many generics we do prescribe. So most doctors are doing their very best, but what patients and insurance companies do not understand is that I don't know a single doctor's office that is not drowning in paperwork. And the paperwork from documenting just about everything, including doing prior auths, including asking for medications, including communications back and forth with the insurance companies. And the healthcare expenditure is not simply about dollars, but it's about work and productivity of the patients who are not getting the therapies that they need in a timely manner. And so you can't put a price on, sickness, on missed school days, on work days, on someone's loss of years. Those are the things that we are talking about, not simply just how much money the insurance company is going to save. And certainly whatever we experience in the office from all this time, energy, hiring people, doing extra paperwork, spending a lot of time on the phone, and drowning in all this paperwork, eventually will be passed on to the consumer and the patients.
I think I said something like this at the very beginning, but the medication that doesn't work is the most expensive one of all. And the wrong medication is among the most expensive medications because it's the wrong medication. And until the insurance companies recognize that as a matter of policy, the physician is in the best position to determine which medication is appropriate. Maybe there needs to be some more education of physicians not to rush into the newest ones, but the important thing is to get the right medication right off the bat, because that's the cheapest way to treat it.
We are just wrapping up now our town hall with step therapy. I did want to just provide everyone on the panel, if you have any closing thoughts on step therapy, and if there's anything else that you think patients can do about this issue.
Number one is to reach out to your legislators. There is a bill available in Illinois that Representative Fine tried to tell us about earlier, and certainly to reach out to your own legislators and ask that they support and at least become familiar with this bill, and in the long run support it, because it will save the state money.
Yes, in fact, it's quite helpful if you simply call your state representatives. State representatives and state senators don't get that many calls from constituents about many bills. And if a number of people will call and tell them how important this is to their health, to their mental health, to their families, and to their communities, that we have access to the medications that work, and that we are not denied the medications that we need, and we are not forced to take medications that are bad for us, that will be good for Illinois, and it will be good for all of our citizens. It's very important that people contact their state representatives and state senators, and people can contact Representative Fine directly and thank her for introducing this bill and encourage her to go forward.
And I would really just, putting on my Arthritis Foundation hat, I would echo what you all had just said, and any way that we can collect patient stories. So for people that are watching that are, from a different advocacy organization, being able to collect those stories so that we can then share with our legislators, that really does help, and it really puts a face to the problem. I've learned so much from all of our panelists in hearing all those different stories that you provided us. I know that is the type of information that our legislators need to hear. So before we conclude, I just wanted to mention just a few more things. This town hall will be archived online, and if you want to find out more information about step therapy and how more to get involved, we recommend going to www.prescriptionprocess.com/step-therapy. If you do have additional questions that you weren't able to ask on this town hall, please feel free to email me at mguadalupe@arthritis.org, and I'll be sure to get that question answered. So with that, I wanted to say a huge thank you to each of our panelists, and of course to all of those organizations, the Illinois State Medical Society, the Sangamon County Medical Society, the Mental Health Summit, the National Psoriasis Foundation, the Arthritis Foundation, Representative Fine. Just wanted to say thank you to all of them for helping make this possible. Thank you.